So we find most acquired diverticuli occur in the sigmoid bone for two reasons. One, the intraluminal pressure is highest there. Number two, the muscularis propria is not structurally reinforced in that area. So any penetrating nerve or blood vessel will create a defect through which the mucosa and submucosa can herniate. Let's take a look at these acquired diverticulitis. This is a resected segment of sigmoid bone, again, the area where you find these most frequently. It's been sectioned a few different ways. You can see the mucosal surface here. And you can see the folds of the large bowel, typical. And of course, you can see the section through the entire thickness through the bowel here. Now you'll notice you can see the different layers. You can see the mucosa and the submucosa. You can see the muscularis propria. Now you'll notice that there are the topography of the large bowel are remarkable for lots of these folds that increase the surface area. The main function, of course, of the large bowel is just to restore water. But you also notice that some areas, the bowel wall seems to bulge into the pericollic fat. Protrusion there, it seems to bulge into the pericollic fat. Here's another one that extends into the pericollic fat. In fact, there are many of these little structures that seem to create blind-ending pouches that bulge right into the pericollic fat. These are all diverticuli. Those are diverticuli. They form when the mucosa and submucosa herniates through the muscularis propria, and now the mucosa and submucosa, it seems, has herniated right into the pericollic fat. Again, biggest problems, you can see how easy it is for fecal lifts, any kind of fecal matter to get caught in here. If it stagnates there, it's going to incite inflammation. It can erode right through that wall into the pericollic fat, possibly creating abscesses, possibly creating a communicating fistula between the lumen of the bowel and the peritoneal cavity. If that happens, you've got all kinds of septic contents spilling into the peritoneal cavity. That's going to cause a septic peritonitis, an infectious peritonitis. And that'll evolve into a septicemia fairly quickly. Okay, let's take a look at the architecture of these acquired diverticuli. I'm going to take a section through that diverticulum there. This is what it looks like on the stained H&E. Okay, so you can see there's the lumen of the bowel right there. You can see the mucosa right there. There's the submucosa, and this is the muscularis propria. And you'll notice the muscularis propria consists of just one layer of smooth muscle. That's the intercircular. There's no outer longitudinal layer you expect here. Instead, what you see is a lot of pericollic fat right there. Now, this is actually a section through normal bowel wall. Everything looks good. It's mucosa, submucosa, muscularis propria, pericollic fat. That looks just fine. Over here to the right, though, you can see where the lumen of the bowel kind of opens up into this blind ending pouch. And that, of course, that's the diverticulum right there. Now take a look at the wall architecture here of the diverticulum. You can see there is a mucosa, there's a submucosa, but the muscularis propria is extremely thin. And that's because the mucosa and submucosa have herniated through much of the muscularis propria. And that's how these diverticuli form. Now, the herniation usually occurs in the wake of a defect created by a penetrating blood vessel or a nerve. If you look underneath the diverticulum, what's that? That's a blood vessel. And that is probably the blood vessel that created the defect through which the mucosa and submucosa herniated. And this resulted in the blinding pouch. Now, complications of diverticuli include diverticulitis, as we mentioned, with the worst complication being some sort of penetration of the wall due to the inflammation, resulting in either a pericollic abscess or a peritonitis. But these diverticuli, even if they're not inflamed, often result in bleeding. Blood vessels very often result in these defects through which the submucosa and mucosa penetrate and herniate, and as a result, these blood vessels are in a position where they can bleed right into the diverticulum, and often the blood is lost as a result, through this bleeding blood vessel. The blood can present very often as some shade of red. These diverticuli occur most of them in the sigmoid colon, very distal in the GI tract. And so typically someone with a diverticulosis will report that they've had instances where they can see streaks of blood on the stool, or they can see some dark red material on the stool. It's very unlikely that they bleed this distally to present as melanite. They would probably present as some shade of red. Questions on this so far? Okay, so we all understand the etiology of these acquired diverticuli. Let's take a look at the radiographic appearance of diverticuli. This is an example of a barium enema showing you someone with extensive diverticulosis in the sigmoid colon. That's where most of these occur. Okay, you can see here, this is the rectum. The rectum vault over here. You can see the sigmoid colon over here. There's the descending colon. You can't see the transverse colon that's over here. And you can see some, in the background, you can see some small valves there that's also sort of complex here. Take a look at the sigmoid colon. You can see the fossa. That's what you expect. That's all normal. You can see the folds, the vaginations. And that's all normal to see in the sigmoid colon. In fact, it's normal to see throughout the large bowel. But you'll also notice that there are these radiographic button-like structures here that seem to communicate with the lumen of the large bowel through this little string radiopacification, a little tunnel there. Those, of course, are the diverticuli. And you can see there are quite a few in this area. Those are all diverticuli forming for contrast. You'll also notice down here, there seems to be a rather large diverticulum hanging off the wall of the sigmoid colon. This is actually an abscess. It would seem that something got caught in the diverticulum that was here. The inflammation eroded into the wall. Fortunately for this person, instead of the contents spilling out the peritoneal cavity, just spilled into peripolic fat and created a very sizable abscess. Very fortunate for this individual because these diverticuli can easily rupture and spill right into the peritoneal cavity. That happened when the person who developed peritonitis. That would have led to septicemia eventually. Questions on this? All right, let's talk a little bit about the etiologic factors involved in acquired diverticuli. Most of the time you're going to be dealing with acquired diverticuli. The congenital diverticuli are comparatively uncommon. So if a patient says they have diverticulosis, unless they specify otherwise, you can assume they have acquired diverticuli in their sigmoid colon. That's where most of these occur. That's what I would expect. If someone said that to me, I would just make that assumption, again, unless I had reason to believe it different. Okay. A few things we need to know about some etiologic factors. The development of these diverticuli, I mentioned before, is related to the high intraluminal pressure generated in the bowel. The higher the pressure, the more likely the mucosa and submucosa will herniate through a defect in the muscularis propria. The prevalence of diverticulosis in the United States is very high compared to other countries. And that seems to be related to the diet that we have. We have a relatively refined diet. We don't have a diet with a lot of food fiber in it. And as a result, the bulk of the stool traveling through the GI tract is relatively low. Because the bulk of the stool is relatively low, it has a very small surface area. Because it has a very small surface area, in accordance with Laplace's law, it takes a lot of pressure to force the stool through the GI tract. Okay? With a lot of crude fiber in our diet, we'd have a bulky stool. That would increase the stool through the jag tract with the same force, you wouldn't need so much pressure. Pressure would decline. Propel the stool through the jag tract with a reduced pressure required because the surface area of both the stool would be high. However, in the United States, we have a refined diet that significantly reduces the surface area of the stool. And as a result, to generate the same force, we have to increase the pressure in the lumen to propel the stool with the same force. And so, in areas where the diet is very low food fiber content, pressure is very high, and it's that pressure that's going to cause the mucosa and submucosa to herniate through a defect in the lower bowel. So it's not a surprise that the prevalence of diverticulitis is very high in the United States because we have a lower refined diet because of that. Okay, let's talk about presentation. So we have diverticulosis versus diverticulitis. Diverticulosis, for the most part, is asymptomatic. Okay, some people will experience the left-sided lower quadrant pain. Why? Because it's the sigmoid colon that mostly developed. Some people will report a sensation of incomplete purging. They feel like they have to defecate, but there is nothing in the rectal wall. Okay. Another complication of diverticulosis is bleeding. For these diverticuli often forms a result of a blood vessel. The blood vessel can hemorrhage right into the diverticulum, and people report some shade of red blood in their stool. The bleed is distal, and so it's probably not going to present as melon. It probably present as some sort of noticeable red-colored blood. Complication of diverticulosis, diverticulitis. Okay, people are going to have left lower quadrant tenderness, again, because most of these diverticuli develop in sigmoid colon on the left. They probably will have a fever. The inflammation can be significant. Bleeding can be even more extensive, possibly leading to an anemia. But perhaps the biggest complication, the most significant complication, is perforation of the wall, leading to septic peritonitis and eventually septic shock if something's not done about it. Okay, the workup. Someone has diverticulosis, okay, and they perhaps even have diverticulitis. You're going to get a CBC. If they have diverticulitis, you will see a leukocytosis. You're going to see increase in white blood cells. Okay, you want to check the hematocrit. They may have an anemia because of extensive bleeding. CT scan can be used to diagnose diverticulitis. You will see matting of tissues around the inflamed bowel. Inflammation causes some surrounding tissues to fuse. You might see that. You also might see any kind of abscesses in the pericolic fat. Okay, if that fails, then perhaps the next step might be a colonoscopy, but you have to be careful with a colonoscopy, because colonoscopy requires you to inflate the bowel under pressure. So if there's any degree of diverticulitis present, the wall of the diverticulum might be significantly weak, and that increase in pressure just due to the colonoscopy could cause perforation. So generally, unless the person has this diverticulosis, as long as the person does not have diverticulitis, and we suspect the person does not have diverticulitis, only then would we do a colonoscopy. If we suspect the person has diverticulitis, we won't perform a colonoscopy because we risk perforation. Darlene? Yeah, question?
I think he's gonna ask you, what's like the clinical difference between the osis and itis?
Osis. So this is just the condition of diverticulosis.
So would it be acute? Is the diverticulitis, like if it's flaming up, then somebody is having diverticulitis, but all the time they have diverticulosis?
Diverticulosis, yes, is the state of having diverticuli. When these get inflamed, we call it diverticulitis, itis, the inflammation. And usually the inflammation is acute.
You can have bleeding with diverticulosis, but it doesn't have to have an infection.
Diverticulosis doesn't need to be accompanied by any kind of fever because there's generally no inflammation.
So there will still be bleeding.
There could still be bleeding based on the etiology of the diverticulum, because it'll be in close proximity to a blood vessel. And it'll hemorrhage right into the diverticulum. Then when itis develops, the bleeding's even worse, because now the blood vessel is being eroded into. There's probably hyperemia in the area due to the inflammation. So it'll be that much worse. And then, of course, you'd expect all the constitutional signs and symptoms of inflammation, fever, for example. Anything else about diverticulositis? Okay. Management, really, it depends a lot on the age of the person. Generally, if someone has diverticulosis, we want to reduce the possibility of developing any more diverticuli, and so we would recommend the person go on a high fiber diet. Perhaps we'll put them on stool softener. That will make it easier for the GI tract to propel the stool to the lumen of the bowel, and that will reduce the pressure. Putting someone on a high fiber diet and a stool softener won't resolve the existing diverticuli. It's not going to cure the condition of diverticulosis. It's simply intended to reduce the progression of diverticulosis. Diverticulitis, generally that has to be managed with antibiotic, and it might have to be managed with surgery. You may have to perform a bowel resection. Generally, if someone's older, we prefer to manage the condition conservatively, put the person on, again, on a high fiber diet, maybe the stool softener. If a person's younger, that condition probably will cause considerable trouble throughout the individual's life, so we might consider a surgical approach. If the disease is bad enough, if the person's young enough, then we might just go ahead and do a bowel resection. Any questions on that? Okay, let's discuss pseudomembranous colitis. Skip this one. Let's talk about pseudomembranous colitis. We talked a little bit about this in microbiology. This is a condition caused by Clostridium diff. It's a gram-positive bacterium. This bacterium normally colonizes your bowel. However, its proliferation is limited by the exclusionary effect. This means that this organism has to compete with other organisms of bowel in order to grow, and because of the competition, it doesn't grow very much. So normally, the population of C. diff in the bowel is relatively limited. However, if someone takes an antibiotic that wipes out the normal GI flora, there's an opportunity for this pathogen to overgrow in the bowel. And when it does, it causes damage to the mucosa of the bowel, resulting in these congealed exudative material to begin forming on the bowel wall. The inflammation, of course, results in malabsorption syndrome, and people develop profuse diarrhea. As a result of the association of the overgrowth of C. diff with the use of antibiotics, sometimes pseudomembranous colitis is also referred to as antibiotic colitis. Now, the name pseudomembranous colitis is given to this condition based on the appearance of the GI tract when C. diff begins to overgrow. When it begins to overgrow, it causes this exudative material to form. This material kind of congeals on the wall of the bowel. It kind of looks like a membrane that lines the bowel wall. but it's not a membrane, it's just congealed exudate. Let's take a look at this. Here's an example of an endoscopy, sigmoidoscopy, of the lower GI tract in a person with C. diff. There's the lumen. You can see how inflamed it is. It's extensive inflammation. Clearly there's a colitis there. But you also notice there's this yellow material on the wall of the bowel. This is that exudate. Very often the exudate is very thick, very viscid, kind of congeals, forms a kind of a semi-solid on the wall of the bowel. And eventually these areas can become confluent and it looks like a membrane is on the wall of the bowel. But it's not a membrane, it's just a lot of congealed exudate. So we call that a pseudomembrane. And henceforth, this colitis is referred to as pseudomembranous colitis, so pseudomembrane colitis. Again, this is typically caused by C. diff. Okay. Now again, it is associated with the use of antibiotics, but not just any antibiotic. Generally, it's associated with broad-spectrum antibiotics. Broad-spectrum antibiotics means that it's an antibiotic that really indiscriminately wipes out a very large series of genera. It doesn't necessarily home in on one specific genus or one specific species. It wipes out a considerable part of the population of the GI tract. So they're called broad-spectrum antibiotics. And there's several broad-spectrum antibiotics that are commonly used that are associated with pseudomembranous colitis. I would remember one of these in particular. It's called clindamycin. Clindamycin. That is a broad-spectrum antibiotic that's used in many different circumstances. For example, one of the more common uses, if someone develops an abscessed tooth. Generally, a dentist will put that person on clindamycin to try to reduce the size of the abscess. We'll get rid of it, but they'll try to reduce the inflammation in the area and reduce the size of the abscess. And clindamycin, since it is used so commonly, is one of the bigger causes of pseudomembranous colitis. Okay?
Dr. Manning, can I ask a quick question?
Yeah.
So, like, you're saying the antibiotic, it wipes out, so C. diff is in the colon or whatever, and then the antibiotic wipes out anything, really. So then you're saying that C. diff then overgrows?
Yes. That normally it can't grow because of the exclusionary effect. You've got other bacteria that are growing, competing with this organism, so the organism doesn't have much of an opportunity to grow. Same thing, it's very similar to, say, Candida albicans vaginitis. Candida albicans colonizes the vagina. Why doesn't it grow? Why doesn't it cause a vaginitis? Because it can't. Exclusionary effect.
Yeah.
If a woman takes an antibiotic, something like tetracycline or something, she wipes out enough of the lactobacilli in the vagina, now there's an opportunity for this organism to grow. So the exclusionary effect is lost when someone takes a broad spectrum antibiotic. Okay, a few other things we want to know. Any other questions at this point? A few other things we want to know. Presentation. Okay, so again, this typically follows after the use of antibiotic. There are other cases in which case the pseudomembranous colitis can develop. It's very common in nursing homes. Sometimes a person can just develop pseudomembranous colitis by ingesting the spores that this organism creates. Remember, this is a gram-positive bacillus, and a subset of gram-positive bacilli can sporulate. This is one of them. This is one of the few bacteria that can sporulate. And so sometimes what happens, the organism sporulates and people transmit the spores from one person to another. If the conditions are right, the spores can germinate and the person can develop pseudomembranous colitis without the use of an antibiotic. This seems to be the case in nursing homes. Nursing assistants get this organism's spores on his or her hand. They don't wash their hands. They go from one patient to the next, spreading the spores throughout the facility. And very often there are outbreaks of pseudomembranous colitis in nursing homes. Also, remember, the spores are pretty tough. So unless someone washes their hands thoroughly, the spores aren't going to be destroyed. You have to wash your hands thoroughly to get rid of these spores. Those alcohol sanitizers are not gonna destroy the spores. And so even if someone were to diligently use an alcohol sanitizer going from patient to patient, they would still spread these otherwise viable spores. So very common in nursing homes. Presentation, diarrhea, of course. The diarrhea varies, can be mild, can be severe. Workup. Usually a experienced healthcare provider can recognize the particular odor of C. diff, recognize the smell of the diarrhea, recognize that it's most likely C. diff. You can confirm that it's C. diff a couple of different ways. Usually, we try to detect the toxins that this organism produces. However, there's a significantly high false negative result, and so a negative result does not rule out Clostridium diff. False negativity is too high. Yes?
But how are they gonna smell it? And then if they smell it, doesn't that expose them to the spores?
The odor is somewhat unique to C. diff, and the spores, you know, they could be aerosolized in the area. Usually, you're wearing a mask, and I don't mean just splash masks. I mean like an N95 mask. Those spores are too big to use a mask like that, assuming the mask is properly fitted to the individual. There generally are precautions that we'll take. If we know that someone has C. diff, you know, wear a gown, wear a mask. You can still get other, you know, get in our hair and whatever, so people are gonna have to be careful. But
How would you smell it then? You know,
you can detect the odor through
but does
the
the person smell it is what I'm asking, I guess, what I'm saying.
No, the stool itself smell, it
So you
smells.
smell the stool.
Well, you of course, you would, if the person's having diarrhea in, say, a bed, a nursing bed or whatever, you're gonna smell it. Ventilation isn't that good.
Jesus Christ.
As a paramedic, how often do you encounter that?
Where I am now, not too often, but previously, frequently.
And where do you typically see it?
Most of the time in nursing homes. Yeah, they have like, I don't know, 40 or 50 patients on the floor, that's when you smell it.
Yeah. Okay. All right. Okay, any case, you know, testing for it, you can smell it. I mean, it has a rather distinct odor. You can test for it. Again, the toxins you can test for, but again, because of the high false negative rate, you can't rule it out because of the negative result. If necessary, you might have to perform a colonoscopy. The way you'd approach this is if there's an antibiotic that is causing the condition, you would discontinue that. You use a more specific antibiotic for C. Okay. Any questions? All right. Let's talk next about bowel obstruction. Just a couple of generalities about bowel obstruction. Bowel obstruction is a condition that can be very painful. Most of the pain results from the incredible distension caused by failure of gas passing distally. You have a bowel obstruction, part of the bowel will be paralyzed, but the bacteria within the bowel continuously produce gases. That's going to cause incredible distension. That results in a tremendous amount of pain to the individual. And that might be in addition to whatever pain can be caused by whatever's causing the bowel obstruction. Okay, a few generalities. Again, bowel obstruction can occur anywhere in the bowel, but the most likely location is going to be the small bowel due to its smaller luminal caliber. It's got a smaller diameter, it's easy to obstruct. Lots of different causes. Let's just talk a little bit about some general causes, and then we'll go into some specifics about small bowel. Hernias, sometimes part of the small bowel will herniate through a defect in the abdominal wall. It can get pinched off, it can be obstructed that way. There are fibrous adhesions, sometimes that form in the peritoneal cavity, due to previous peritonitis. Sometimes the bowel can get wrapped around that, it's called an internal hernia. Okay, that can cause obstruction. Intussusception, we'll talk about that. That's a condition where a proximal portion of the bowel herniates into a distal portion of the bowel, causing obstruction. Volvulus, the bowel twists on itself, very painful. Tumors, inflammatory strictures. You can see that, for example, in conditions like inflammatory bowel disease. Some other things, pseudo-obstruction, paralytic ileus, which is now called adynamic ileus. That's a condition where the bowel is functionally obstructed. It's not mechanically obstruction, but it is no longer peristaltic, it's aperistolic. That results in a functional obstruction. And very often this can occur as a result of abdominal surgery in the post-operative period. Generally, when someone has abdominal surgery, we want to monitor the function of the bowel. The way we do that is actually ask the patient if they pass gas after the procedure. If they pass gas, that's a good indication that the bowel is beginning to recover its function. Okay? All right, let's take a look at all of those different types of bowel obstructions. First, we'll talk about the abdominal hernias. Okay, again, defect. Typically, this is caused by a defect in the abdominal wall. It could be some sort of previous surgical scar. It could be along the inguinal femoral canals, along the umbilicus. Whatever be the case, sometimes a loop of small bowel will herniate through a defect in the abdominal wall. Very often this will occur after some illness that causes the person to constantly cough. They're coughing, they're raising the pressure inside the peritoneal cavity. This can cause an opportunity for a bowel to protrude through one of these defects in the abdominal wall. Now, generally, when a loop of bowel gets caught initially in a defect in the bowel, in the abdominal wall, generally you can just take a finger and push the loop of bowel back in. You can reduce the herniation. However, if the loop of bowel stays in a herniated position long enough, the inlet pressure around the herniation can cause an obstruction of venous return. That's going to cause high hydrostatic pressure in that loop of bowel. The bowel is going to become edematous, it's going to swell, and it's going to get stuck in the herniated position. That's called an incarcerated hernia. As the edema continues to develop, it can also collapse an arterial supply, and that's going to cause strangulation, ischemia. That's called strangulation. Okay. Peritoneal adhesions, another common cause of bowel herniation. Peritoneal adhesions, if you recall, these fibrous, just lots of these strands of fibrous tissue that generally span the width of the peritoneal cavity, can be caused by a previous peritonitis, some sort of surgery, for example. A loop of bowel can get wrapped around some of those herniations and become internally herniated, and the same process happens eventually. It gets strangled. Fecal impaction. This happens with children a lot. Sometimes a child is infatuated with what they're doing. Maybe they're playing. They have to go to the bathroom. They have to defecate, but instead they defer. They constantly defer. The longer they defer, the more dehydrated the stool gets, and sometimes it forms a very hard fecalith that obstructs the entire lumen of the rectal hole, the entire rectal canal. And as a result, the child's obstructed. Two ways you can deal with this. Probably the better way to deal with it is administer a warm water enema that will hydrate the stool and make it easier for the child to pass. There's also another method that's relatively unpleasant. It's called digital decompaction, where you can take a gloved finger and you can dig out the stool. It's not pleasant for the kid nor the caregiver, but it's an option. Okay. Any questions on that? All take a break here, and then we'll talk about muscle second.